I'm sure the audience is curious at this point, like you're cutting a bone from the human body. So, doctor, being an experienced shoulder specialist, what are the different kinds of surgeries that you come across?
Early 20s, high chances of non-healing and redislocation. If you look at the numbers, around 85 and 90% patients can redislocate if they are in their late teens and early 20s.
So, after this operation, is my shoulder going to be completely 100% all right?
Remaining you recovering to 100%
Yes.
is fully in your hands.
Hi everyone, welcome to Athletes Coffee Club. This is a space where we sit down, grab a coffee, and talk about real sports injuries, interesting cases that come across, and the lessons we learn from them. So today we have Dr. Ayyappan Nair with us. Can you please introduce yourself, Doctor?
Sure, Priya. I'm Dr. Ayyappan Nair. I'm a consultant shoulder and a sports trauma specialist at Manipal Hospital, Whitefield. I'm very thankful to Priya for giving me this opportunity, where this is a new podcast which we have. And this is basically on not only surgeries, but also we will be talking about sports medicine, which includes nutrition, psychology, conditioning, etc., as well as sports physiotherapy. Today, I'll be speaking on interesting cases because we do a lot of shoulder and sports surgeries. So I'll be talking about the interesting shoulder cases which we have done over the last 1 month.
So, Doctor, being an experienced shoulder specialist, what are the different kinds of surgeries that you come across?
Most of the surgery is divided into basically three categories.
Right.
One is shoulder dislocation surgeries. The shoulder dislocates. It's one of the most commonest joints which dislocate.
Right.
Second is muscle tears in the shoulder. Some people come with certain nerve compressions. And the lastly, shoulder replacement and fractures, which they come into the same category. So if it is a young patient, mostly it is a dislocation.
Okay.
When the patient comes, if it's like 50, 60-year-olds and above, it is mostly muscle tears.
Okay.
Fractures can come in any age.
Okay.
But certain fractures are so bad that you have to do a shoulder replacement.
Okay. Very interesting, doctor. So about shoulder dislocation you mentioned. So do you have to do a surgery on every case that comes?
Yeah, it's a very important question because surgery is not required in all cases. There is certain logic behind it. The logic is that, see, any joint, including this particular joint, if it dislocates, but twists like this, it can dislocate. So what happens is what prevents a dislocation is there is a ligament. Ligament is like a belt-like structure, which you
Right.
can't see. It is deep inside,
Okay.
which connects these two bones. The ligament is holding. That's why it is not dislocating now.
Right.
Now, if I suddenly give more force, it will dislocate.
Okay.
And if I keep it in this position for some time, around 3-4 weeks, it will heal up.
Okay.
But the shoulder ligaments are notorious for not healing.
Okay.
And especially when the patient is much younger,
Right.
when they are in their late teens,
Right.
early 20s, high chances of non-healing and redislocations.
Okay.
And if you look at the numbers, around 85 and 90% patients can redislocate if they are in their late teens and early 20s. So, if it is a first-time dislocator, you need not operate.
Okay.
You need not, because you can maybe the patient can fall into the 10 to 15% category.
Right.
Maybe they can heal up.
Right.
So you need not necessarily operate.
Okay.
You wait and watch.
Okay.
Put the patient through physiotherapy, immobilize the shoulder for some time, and normally patient recover in 2-3 months.
Okay.
Then in the future, if they dislocate one more time, that means this ligament is not healed up.
All right.
That is the reason why you operate on second-time dislocators.
Oh, interesting.
But at the same time, the story is very different when you've come to an athlete.
Right.
If you're an upper limb athlete, you're a javelin thrower, a cricketer.
Right.
If you don't operate after the first time, then what happens is, so he is at very high risk of redislocation.
Okay.
His entire career goes. So that means in an athlete, you dislocate the first time, it's you so operate on the first time itself. Non-athletes, you can always wait for the second time. So if you're a normal person living a normal life, an occasional athlete, you need not undergo surgery first time, but second time, yes, you do definitely require a surgery.
Those were definitely very great insights that normal people like us don't know. And thank you so much for sharing those insights. Now, moving on, do you want to share about more procedures and
Yeah. So if you look at shoulder dislocation surgeries, it is not like one surgery is for everybody. It is not like if any patient come in, it's not like that. If you look at the most important thing which you look at in a shoulder is one, if you feel that some patients are more flexible, it's called laxity.
Right.
So hyperlaxity, we can do a scoring. So how do you know you're hyperlax or not? So you can ask the person to touch. Can you do that? Can you touch your thumb against the back of your hand? You are almost able to do it. And can you do like this? This should be like parallel to the hand. Yeah, you can take a little more down. Yeah, it's on camera. So then next is you do the hand like this. So if you see, this is not going hyperextended. It is straight. So then again, you do similarly for the knees. Ask the person to stand up. See if it is hyperextended. Then lastly, ask the person to touch the floor with the palm of the hand. Floor. Without bending the knees. If you're able to touch it, that means you're more flexible. We call that as a scoring called as a Baton score. This Baton score, if it is higher Baton score, that means you're more flexible. So you are at more chance of failure of surgeries. You need to do additional procedures when you are operating. There is also a particular test which we do, the surgeons do, to make out if the patient is hyperlaxed or lax or not. Then just straightforward procedures are not enough. We have to do small modification in the surgery. So that depends upon the surgical skill set. So now overall, so having told about one is hyperlaxity, and another thing which is most important in shoulder is a ball socket joint. This is the ball and the socket. So this is the front, this is behind. Mostly dislocation happen in the front. When I take my hand like this, it goes out. And it comes and bangs back like this. This banging, it's like denting between two cars hitting against each other. There's a dent on both the cars. This bone denting on the ball and the socket is called as bone loss. In that bone loss, most significant of the bone loss is when it is concerning the socket or the glenoid. Socket is called as a glenoid. So there are a few things very interesting about the shoulder. Shoulder is you can rotate the shoulder completely. It is the most flexible joint. So this flexibility will happen only if the bone structures are in a particular way. The socket is always one smaller than the head. Even though I'm showing my hand is big, actually it is only the head is bigger. And the socket or the glenoid is only 1/3 the size. So that is why it dislocates, because it can slip out anytime. This holding of the shoulder is by these ligaments. So when the shoulder goes in an abnormal way, these ligaments can break. But then when it dislocates, this will come and bang back like this, causing a denting or bone loss of the socket. This bone loss is very significant because if the bone loss is, for example, the cutoff value is 13.5%. To 5%, you can still just repair the ligaments. That procedure is called as a bang cut. 10% still okay. 13.5%, the bone is this much is gone. You have only this much bone. So now, because the bone is less, it will more easily dislocate. So you need to put additional bone like this and graft it and make a normal bigger socket like before. So this is important, and that's why I said surgery is not same for everybody. Mostly the surgeries are soft tissue surgeries where the bone loss is less. The bone loss is more than 13.5%. You need to do a procedure called as Latarjet procedure. There is a category in between. Latarjet is basically, there is a bone here, you cut it and put it in the front. This bone or the graft can be taken from multiple places. You can take it from here, you can take it from behind, you can take it from the hip. Artificial also comes. Any choices. So basically, to sum it up, shoulder dislocation surgeries of two types: soft tissue surgeries and bone surgeries or bone grafting surgeries.
Thank you, doctor, for explaining such difficult concepts in such simple way. I'm sure everybody has benefited from it. So can you show us in pictures how it looks like, the injury looks like, where the ligaments are and how you treat it?
Sure. So Priya, you can see this is a picture of the shoulder joint. You can see the picture here on the left side. So this actually shows the ball and the socket joint. Now, so this is the ligament which I'm talking about. You can see how it is very important structure connecting these two. So there's again another picture of the ball, socket, and the ligaments. You can see a tear like this. This is the most common tear which is there in shoulder dislocations. So basically, it's very simple. If it's just soft tissue surgery, just have to stitch it up like that.
Interesting.
And this is what I was talking about, the bone loss. You can see this is a normal socket. You can see how rounded it is. And we can see because of the bone denting, how much bone defect is here. So if this is more than 13.5, you have to put an additional bone. So similarly, a bone denting happens also in the head of humerus, the ball. That is called as a hill sash lesion.
Okay.
We fix that also during a surgery. You can see in X-ray how an hill sash appears.
Right.
This is how an arthroscopy is done. You can see multiple small keyholes. The size of the camera is like 4 millimeter.
Right.
So you part, this is the camera, and through the other holes you operate. This is the latagia which I was talking about.
Right.
So I mentioned, I showed you a picture of that bone loss.
Yes.
You can see that in the shoulder, there is an accessory bone in the front of the shoulder, called as a coracoid process. So you take that bone and fix it in the front.
Right.
This what you see there, the latagia, is basically a older technique. People used to do it as open, and it used to be fixed by screws.
Right.
Now it is modified.
Okay.
So advanced techniques come where you can see you drill from the socket into the bone
Yes.
and you pass this button and loops. This is called as the cortical button,
Right.
and then you can tension it. It works like a screw.
Right. So you don't use actual
Screws are not required anymore. That is
Yes.
an advantage of your
Right.
technology.
Right.
And this is a lot of people do ask, what is I mentioned about a hill sash. Hill sash is a defect in the head of humerus. And you can see how this muscle is tied up into it. That's called as a remplissage procedure. So these are the simple facts about shoulder dislocation. And you were asking me interesting cases which we did. Hey, doctor, you mentioned about different grafts, and you showed one technique. I've heard of this spine of the scapula. What is the spine of scapula, and how do you use it in shoulder dislocation?
So, doctor, you mentioned about different kinds of grafts that are used in this latagia procedure. So here we have modular of the scapula of the shoulder. So can you show the different kinds of balls that you use
For
for?
grafting?
Yes.
Yeah. So this is the front of the shoulder. This is behind. The front is called as anterior, and this is called posterior.
Right.
So you can see the small bone here. If you look at it,
Yes. Yes.
you can see this bone.
Right.
This is called as a coracoid process.
Interesting. Yeah.
So this is adequate enough to replace up to 25% of the bone defect.
Okay.
If up to 25% of the glenoid socket is gone, you can replace with this.
Okay.
More than 25%, you need additional bone from the hip.
Okay.
So here we cut it.
Right.
So we have cut it like this, and then you can see this muscle in the front.
Yes.
We split it open and put it inside.
I'm sure the audience is curious at this point. Like you're cutting a bone from the human body. So does it cause a problem at that point or?
It is a vestigial bone.
Right.
That means it does not have any role in human beings, but in four-legged creatures, it is very important. So your question was, Priya, that if you cut this bone and use it for latagia
Yes.
procedure, will it affect the function or is it harmful for the patient?
Yes.
This is a vestigial bone in human beings.
Right.
So removing it does not affect any kind of functions.
Okay.
The procedure is so strong
Right.
that if you are an contact athlete, you're a rugby player, you can go back to rugby. It is that
wow.
strong.
Okay.
So, and it does not cause, this is bone is more important in four-legged creatures, more the quadrupeds than human beings.
That's great.
And you're asking which are the other bones.
Yes.
So it's very interesting. So in the shoulder, there's a back of the shoulder,
Yes.
or it is the scapula,
Yes.
the shoulder blade, where you can see this wide portion. This portion
Right.
is quite wide. And so we cut off this portion like this. So measuring into a 1.8 into 1 into y. So rectangular piece of bone is taken. This also can, this surface, you see, it is a nice surface. It gives you so much of surface to, give coverage to the puppet.
Okay.
The other is, you can see the collarbone. This is called as a clavicle collarbone.
Right.
You can take a portion of this. But I don't prefer it because
Okay.
it affects your joint. It is a normal joint. Why take it off? You can take from here, but here I
Yes.
wouldn't take.
Okay.
But definitely, if the bone loss is more than 25%, then
We might have.
Ilia crest, we call it, we take it from there.
Okay. Interesting now. So, moving ahead, do you want to discuss some interesting cases you have seen like in the last month?
Yeah, it's very interesting to see that and also every week, every day.
Yes.
In one of the good things about medicine is that
Yes.
you get to see more and more different things, different people with different set of problems. Mostly it is not the repetition all the time. So this I was mentioning about the spinoscapula.
Yes.
And mentioning that. So this is what exactly I was trying to show you. You can see that I was planning to cut off in this area. You can see a rectangular piece of bone, number 4, has been cut.
Okay.
So You can see how we have taken this. You can see the bone like this measurement,
Right.
and you can see how it is fixed
Right.
in front of the socket. See this with the socket, how additionally it gives you giving more coverage to the socket. So this is your scapular latae. So we had a patient, around 24-year-old, multiple time shoulder dislocation. So
Okay.
there's 12% bone loss.
Okay.
So if it is 13.5,
Yes.
you need to do the coracoid. That means you need to do this.
Right.
If it is, there's something called a subcritical.
Hmm.
That is supposed to be between 10 and 15%. So,
Okay.
but this particular case which I'm discussing, around
Yes.
12%.
Right.
It is not significant enough for me to take the coracoid. I want a smaller piece of bone.
Okay.
So as a surgeon, what do I think? So why do I want to take a big piece?
Hmm.
Why should I affect a joint as such? Take a small piece from behind. They don't affect the patient function. It's a small procedure. And then in this, if I take this, I don't have to dissect too much inside. Very quick procedure. So what we did is we fix it like that, and that's called as a spinoschapula, a target.
Right.
12% bone loss. Just
Right.
just in case. We have another case.
Right.
The patient came to us with around 22% bone loss,
Hmm.
where we did arthroscopic latae. So latae, I showed you the picture earlier,
Yes.
how the latae is done,
Yes.
the coracoid process, how it is cut.
Right.
Earlier, it used to be done as completely as open surgeries. So there have been a lot of modification, a lot of surgeons all over the world contributing to this. There is this surgeon by name Lafos.
Okay.
He developed an arthroscopic technique to fix it. Then, but with screws. Then another surgeon by name Dr. Pascal Bolu,
Right.
who I visited. So he was doing it as with the buttons.
Yes.
So the surgery takes around 1.5 hours,
Okay.
and we have to do a combination. It's just not the piece in the bone.
Hmm.
We have to put the bone, increase the surface, do a ligament repair, and also do the research.
Okay. Interesting. So, any other cases you want to discuss?
Yeah, more than other cases.
Yeah.
So what everybody want to know is,
Hmm.
as a let me ask you, like, suppose your relative is come with come for a shoulder surgery, dislocation surgery. What are the question normally you'll ask?
So as a layman, actually, dislocation.
So what do you want to do before surgery, after surgery? What are the common questions you might ask?
So I would want to know if it's a major surgery.
Yeah.
I would want to know if it causes pain.
Yeah.
If I can.
Let's go one by one.
Sure. So.
Major surgery? Yes, it is a major surgery.
Okay.
So why is it major surgery? Because it's not a simple ligament repair and all it. So even though it is done arthroscopically or a keyhole surgery, but the procedure itself is a major surgery with general anesthesia.
Okay.
Yeah, next question.
Okay. So how many days are we going to be admitted, and what will be?
Normally 1 day is enough.
Okay.
So you admit today evening, so do the surgery tomorrow morning, and day after tomorrow discharge.
Interesting. So can
But-
we start working again, or if we need to use
So
the-
you asked this question about pain.
Yes.
So how do I know that if you're pain sensitive or not pain sensitive?
I will tell you if I have pain.
So you can't actually judge, because some people can judge saying that if I'm little pain sensitive,
Right.
back or tolerate pain.
Okay.
Some patient can't.
Okay.
So that we will know only after the surgery.
Interesting.
So if you look at our data,
Hmm.
80% patients don't have any pain.
Is
They're very comfortable to get discharged next day.
okay.
20% will have more pain. That's all.
Okay.
Then how long does the surgery take? See, if it is a bankard, around 45 minutes. And latae with ligament repair and all that will take 1.5 hours.
Okay. And then they have to stay just for one more day in the hospital, and then I
Yeah,
can go.
Yeah.
And after going back home, do they need some special care? And how about that?
So now the question is, all this care, everything revolves around one major factor,
Hmm.
the healing.
Hmm.
So if you do any of these procedures, a bankard repair, or if you do a latae, the healing happens by around 6 to 12 weeks,
Okay. About 3 months
3 months. So the recovery process also will be in the same timeline.
timeline.
So you have to modify
Hmm.
your physiotherapy protocol, rest, everything according to this 6 to 12 weeks time.
Okay.
So now in my practice, first 6 weeks, a sling is required.
Okay.
And patient does home-based exercise. You don't require physiotherapy. It's a simple exercise which you can do. And home-based exercises are required.
Okay.
Next 6 weeks, you need physiotherapy.
Okay.
Very meticulous. So these are non-negotiable.
Okay.
So if I normally I tell ask the patient that if you can't do the physio from 6th week to 12th week, don't do the surgery. That's what I tell the patient. It's very, very important.
Right.
And if you do everything correctly, by 3 months you'll have a perfect shoulder.
Right.
That is in our 80-90% of our patients.
Right.
But 10% are outliers. They might take more time, more effort, and therapy might be required. That we can't predict.
Right.
But most of the patient falls into this category.
Right.
Then another thing he asked me was any restrictions as well.
Yes.
So especially, see, today's era, everybody wants to be very active,
right.
but we have to protect the repair also. So first 2 weeks, we don't allow any hand movements, as only just elbow movements allowed.
Right.
After 2 weeks, they're allowed to type.
Right.
So you can take out the sling for 3 things. Taking a shower,
Okay.
you can leave it down.
Okay.
Number 2 is self-exercise which we teach you at home,
Okay.
home exercises.
Okay.
Third is for you to take it.
Okay.
Otherwise, mandatorily out of it.
Okay. One question that comes to your mind is there any angle that has to be avoided? You said that we can take the sling out for bathing. So can we utilize the hand?
It should not.
Right.
The hand has to be always close to the chest.
Right.
Because again, the orthopedics is it's simple mechanics.
Right.
So they call orthopedic surgeons, other specialties call us carpenters.
Right.
So basically, because it does not involve too much of it is just logic. So the shoulder is held by the ligament.
Right.
If I try to move like this, the repair will come up.
Okay.
So you're allowed to move in front direction
Okay. Okay.
and rotation 10 degrees.
Right.
The side movement is not allowed.
Sure.
Side movement is allowed only much later in the recovery process.
That's a very important point doctor has shared with us.
Imagine you are the patient.
Right.
What else will you ask me?
Otherwise, I'm not, but
I really hope you're not. But what I'm asking is, what else will you ask me?
so I want to know, you said I can type. So typing work and all, I can continue after 6 weeks timeline. Interesting. So after this operation, is my shoulder going to be completely 100% all right?
Awesome. That's a beautiful question. So that's what question everybody should ask. So the answer is, so it's like this. So you should know about the complications. When you after doing your surgery, what are the complications? Knowing the complication will give you your answers.
Right.
One is repeat dislocation. Even if I operate on you,
Yes.
will the shoulder dislocate again? It can.
Okay.
What is the data?
Right.
8% to 28%. It's a variable range.
Okay.
How many of my patients? So in my entire practice, I had around 4 patients who had repeat dislocation.
Okay.
How many would have done? I would have done thousands. So when we look at it, so mine would be much lesser than the 1 in like 1,000 types.
That's clear.
That's not because I'm doing something early out of the box. I'm lucky. Patient is lucky. It's God's grace.
So I'm sure there's something more you add on to the mix.
Yes. Okay. So that's why I mentioned so much in detail earlier that is choosing the right surgery for the right patient. Soft tissue surgery for subcritical, if it's only a ligament repair.
Right.
Subcritical means we are doubtful that then they go for a spinal scapula.
Okay.
You add other procedures like limb massage, rotator endeavor approach, like small techniques you have to do. And if it is more than 13.5, definitely a target. And if it's more than 25%, really aggressive, bigger bone graft.
Okay.
So choosing the right surgery for the right patient will actually keep your recurrence numbers less. But if you ask, hey, doctor, what are the biggest numbers? Okay, what are my chances of dislocation? 28, 30%. That is the highest data. Normally, when will it happen? Will it happen immediately? Normally within 3 years.
Okay.
3 years is the peaking. That's
Right.
when the repeat dislocation can happen.
Right. Right.
And yeah, some other complications are like weakness, stiffness, inadequate physiotherapy. Lastly, infection.
Okay.
Infection rate is 0.1%, 1 in 1,000. So infection is out of this most dreaded complication is infection.
Okay.
How do you avoid infection? You can't technically avoid it because as any surgeon, any doctor, we take all the precautions.
Yes.
Why is it some people get infected?
Yes.
Infection can come from reduced immunity like diabetes, rheumatoid, etc. Infection can also come from when the skin. We have throat infection somewhere in the body can go and sit in the clot there.
Okay.
When there's a maximum infection rate within 6 weeks.
Okay.
So it is important to keep seeing your doctor every
Yes.
2 weeks frequently so that he can assess you.
Mm.
So I normally tell all this to patients that if there is a problem, you should always come to me
Right.
immediately.
Right.
All this can be corrected. So
Right.
answering your question, your recovery is in your hands.
Okay.
I can just do the repair
Yeah.
to best of my ability. Remaining you recovering to 100%
Yes.
is only in your hands. Physiotherapy, home
Yes.
exercises,
Yes.
protection. Do this correctly, and you'll have 100% movement and power in 3 months.
Oh,
You can play sports in 6 months.
wow. Those were such interesting points you shared with us, Doctor, which we normal people do not really understand and know. Thank you so much for breaking all the points so beautifully. So, moving forward, is there anything else you want to talk about?
We had this particular case. Okay, so of a muscle tears. Okay, if you look at the shoulder, so I can show you some muscle tears. So this is this picture. This is again, I don't know. So this picture is of the ball socket joint, and these red color things are the muscles.
Right.
So you can see a gap here.
Yes.
That is a muscle tear. It's a very common condition.
Right.
It's very common, and especially middle-aged, little older age. You can see this muscle.
Yes.
Red color is the muscle belly. Then the muscle continues as a tendon,
Right.
which is whitish in color.
Right.
You can see there's a tear.
Right.
The tear has become bigger,
Right.
more bigger, and keep on going back. This is called as a rotator cuff tear. When the patient comes earlier, you can do a very simple repair. You can do an arthroscopy, camera inside, repair it. So it's a very simple repair, not very complicated.
Okay.
But the problem is some patients come neglected. They come after a long time.
Okay.
So we had this particular case where we could not pull the muscle back.
Okay.
It was already in grade 3 retraction, which is basically this.
Okay.
Muscle has gone back. That means
Right.
instead of it is sitting there.
Right.
So you can't just pull it.
Okay.
So you open the inner part of the upper back, that is around this shoulder blade, and do a procedure called as a muscle advancement.
Okay.
Muscle advancement. So you can see I'm opening this area. And then what I'm doing is, this is this area. You can see the muscles covering like that. Muscles and muscles be like this.
Yes.
So you can see that I look at this particular picture where I'm sliding this muscle or releasing it back. That means I'm pushing it.
Okay.
Release,
Okay.
slide.
Okay.
That's called as a muscle advancement or the slide.
Okay.
So you can see this picture after slide it, you can see I'm able to bring it back to its position.
Right.
This is the latest thing which we do. It's a wonderful procedure. And there are a lot more other procedures like SER and all that. But this is the simplest thing to do. So do this. It takes 10 minutes extra in your repair,
Okay.
but gives you wonderful results.
Okay.
And you can see how the muscle after sliding will come and sit over here.
Right.
And you can see how wonderfully it is recovered. But only catch is the surgeon should also release a nerve in that area.
Okay.
So you can see this is this part. You can see this first portion.
Right.
There is a very important nerve which supplies the muscles over here.
Okay.
You can see the yellow thing.
Yeah.
You can see the nerve.
Yes.
That nerve has to be released. That requires training by the surgeon. The other one is simple. You just have to open it. But this has to be arthroscopically released, and then actually it gives you wonderful results. So again, we had a very interesting case where patient came with a massive tear. We did a muscle advancement. It came with a beautiful repair.
Okay.
So we'll be sharing the videos of that as well. Right. It's quite thrilling as a surgeon. So there are so many things you can do.
Right.
And so other is we have this collarbone, the clavicle.
Yes.
It can fracture. Normally, a fracture of the collarbone is in the middle. Sometimes it can be here. It's called as a outer end or lateral end.
Okay.
So this particular patient came with a lateral and clavicle fracture.
Okay.
So a lady patient who had a slip and fall, and a young patient. So what we did was the problem was this particular bone was very small. So I had to put a plate screw to fix it. But the thing is, just putting a plate, because the bone fragment is so small, you can't have 5 screws there. You can have actually 2 screws. Small screws can be put. You can see this picture over here, where you can see how the collarbone is fixed by this. This plate is called as a lateral end clavicle plate. But just not fixing is not enough. This is an older technique. Can you see this long screw?
Yes. Yes.
Yeah. So that is called as a Bosworth screw.
Okay.
That's an older technique.
Okay.
If you put that screw, then you can't move the hand much.
Okay.
The brick.
Okay.
You could also put something called as a hook plate.
Yes.
But you can see here, because you can see our plate comes like this and hooks under the
Okay.
like this one.
Right.
Again, you can't move the shoulder much. If you move too much, it will break out,
Okay. It'll break the bone.
break the bone, and it will undercut the bone.
Okay.
So we do a technique where we put a loop through this coracoid. I was mentioning about this bone.
Yes.
Can you see this? See this ligament?
Yes.
So we need to put a loop around this, drill through the coracoid and put like this and fix it.
Okay.
So you can't see this in the X-ray. It is done arthroscopically.
Okay.
That along with the plate gives you a complete fixation.
Okay.
That's the advanced technique which we do. So arthroscopically you fix it and then put a plate on top, so that otherwise the chance of plate coming out is very high. Why? Because the bone is very small. That's another thing which we do. You can see, again, you can see the collarbone fracture here. You can see the ligaments are here. So I basically drill through, put it like a loop like this. And then along with that, we put a plate on top. So we'll share the videos of that as well. And there's another interesting case which we had.
These are such innovative cases, doctor.
Yes.
And so good.
It is very interesting because so much of the advances in medical science that you have so many options
Right.
to give wonderful results to patients.
Yes. Yes.
And these are some of the surgeries it's quite exclusive to us because, so our techniques, our own techniques are there. Then lastly, the most important one now is like, we had this particular patient who came with a fracture of this humerus.
Okay.
And he was operated elsewhere. But there's a problem in this humerus fractures. It can cause a condition called avascular necrosis.
Okay.
AVN.
Okay.
Like Ayyappan V Nair, AVN. Avascular necrosis.
Right.
So this avascular necrosis, basically, even if you fix it,
Yes.
the bone collapses.
Okay.
And if you put so this is the bone. This is a normal ball socket ka ball. And I have put screws and fix it like this. So the screws will be going here into this ball. Imagine one fine day it starts collapsing. The screws become prominent.
Okay.
And the screw will start rubbing on the socket.
Okay.
That patient came with a significant bone defect. So we will show you a picture of a video of the 3D printing. We did a 3D printing. And also we have a software called as a blueprint software, where we did an extensive planning. And when I was operating, so because of the planning, it's an AI-based planning software, which we can measure the size, how much, because the patient, the socket there's a defect in the socket.
Right.
So we were able to compensate that socket, make it into bigger. Then it was very, very challenging cases. And so because it was one of the most challenging cases I've done in shoulder replacement.
Okay.
Because everything was kind of sticky inside. And the bones, everything was malformed. We have to take out that bone. Then, in spite of so much of planning, still we had to struggle to put the ball socket in its place.
Okay.
So every step of that surgery was really, we had to think a lot. Yeah, so very thought-provoking, and every step, it is not like I could just go and finish it up. It's not like that. So if I have to expose this humerus, I had to take effort. Because and the bone was completely instead of round shape, it is within like a triangle kind of thing there.
Okay.
Then exposing the socket is difficult. The socket is completely tilted. So that planning will definitely show we'll show a blueprint planning video.
Sure.
And when we're operating, because of the 3D printing, we could actually see the defect, and I could actually keep the implant on top of it and see that, this much correction I'm able to get. So I had to put in simple, to correct the glenoid defect or the socket cut defect. I had to put bone graft, put a specialized augment, and then I had to reduce it. Reduction although was extremely difficult, but in the end came out very beautiful. So that is another very interesting case which we did this month. So we will show in detail
Okay.
about this, like how it is that people can understand about the surgeries.
That's very interesting, doctor. And as you said, avascular necrosis, Avian in the patient failed his shoulder, but you, Avian, Ayyappan V Nair, saved his shoulder. So that's really interesting. Moving forward now, any other cases it comes to mind?
I think this is the good for the month. I really thank you, Priya, for taking this opportunity. So I've not got my coffee yet, but maybe next time Priya will give me my coffee. So thank you so much.
Thank you so much.